Well, what we talked about was on dermoscopy of special sites, and it was a little over 3 hours long. So it's going to be tough to kind of condense it down into this question. But from a simplistic standpoint, the first and most important thing was to recognize that special sites in dermoscopy are defined by um, areas of the skin where the microanatomy differs from the rest of the non-glabrous skin on your body, except the face. So the non-glabrous skin obviously is everywhere other than palm, soles, mucous membranes, and nails. But on the non-glabrous skin, the face is a special site because the microanatomy on the face differs. And that is also true for the glabrous areas of the body, so palms, soles, mucous membranes, and nail unit. And because the microanatomy of these areas differ, the dermoscopic structures and the interpretation of those structures will be very different than the rest of the body. And so the first thing that we covered during that lecture was facial skin. And I think the take home for facial skin is to recognize that facial skin has an attenuated reedy ridge pattern, so it's kind of flattened. And anything that's pigmented will be kind of homogeneous in its pigment. And the only thing that interrupts that homogeneous pigment are hair follicle openings. So you end up with a pseudo-network pattern. That's fundamental understanding to then go forward to understand the difference between benign and malignant. And the next thing that we kind of stressed was that melanoma on the face is derived from the stem cells that reside in the hair bulge. And therefore, early melanoma is follicular-centric. So there's hyperpigmented follicular openings, irregularity around the follicle. Everything is around the follicle and the extension from the follicle outward, as opposed to benign lesions, which will be interfollicular, will be where the changes are, not the follicle. So I think that was sort of the key take home, and then obviously the subtleties are beyond the scope of here. We then covered palms and soles. And I think there the most important thing to understand is that we have our dermatoglyphics, so our fingerprints. The ridges are where your eccrine glands open up, and the invaginations of your dermatoglyphics are narrower, right? So that's what creates the fingerprint. The stem cell for melanoma on palms and soles resides around the sweat gland. And therefore, early melanoma, since the sweat gland is associated with the ridge of our dermatoglyphic, then in early melanoma, the pigment will be on the ridge of our dermatoglyphic. And in benign lesions, it will be in the furrow. And this is a fundamental understanding to differentiate benign from malignant. And when you have a lesion where the pigment goes from ridge to furrow to ridge to furrow, where you no longer can tell the difference between ridges and furrows, that is also considered concerning for melanoma. So the melanoma-specific structure for palms and soles is a parallel ridge pattern, for the reasons I just mentioned, or irregular diffuse pigmentation that crosses ridges and furrows. And then we went into details of the features of benign, but I think the take-home for the melanoma, at least, was that. And then we spoke about the nail unit. I think one of the newest things that we learned about dermoscopy of the nail unit is actually not dermoscopy. It's the realization that there are clinical features that eclipse what you see on dermoscopy. And that includes if there's nail dystrophy, if the pigment encompasses more than half of the nail, if there is the band in the nail has a triangular shape with the base of the triangle being wider than the distal part, that those are features that eclipse anything that you would see on dermoscopy. And then if you don't have those critical features on clinical examination, then you go into dermoscopic features. And then we spoke about the difference between regular and irregular lines within the band that helps us to define benign from malignant, also known as, is the lesion maintaining its parallelism in its lines versus disruption in parallelism. And so those were sort of the key things that we spoke about, at least from a melanoma perspective, and then covered lots of benign lesions and what their characteristics are. But that's pretty much what we covered in about 3 hours, or 3.5 hours.